So before I even start, let me make a point here that I think is important. I am talking to you from New York, so from the US, which is the worst hit country. And my whole family is in Brazil, which is the second worst hit country. So I already want to say my view on everything that's happening right now is extremely pessimistic and punctuated by a lot of personal anxiety about everything, of course. And so to take in consideration, I think it's important. But I also think that makes me bring some views that maybe it's not shared with everyone, but I think it's important. So there's also a part of me that just wants to bring attention to what's happening, especially in countries like Brazil. So the title of my presentation today is Inequality and COVID-19 in Brazil and the US. And I've combined actually results from mostly two papers, a little bit from a third one, which is in Portuguese, which is why I haven't shared. But if anyone wants that, it's actually a public policy note that is available at Magi's website. I can send later. And so the kind of main narrative of the two main papers that I'll be discussing today is very similar. Basically, we analyze, and I have different co-authors in each of those papers. And basically what we did is to analyze how inequality and the pandemic interact with each other. And the main argument and the main intuition that we had when we started going on this was because we're so unequal, we're going to observe unequal results. And because this is a public crisis, those unequal results can lead to even bigger economic and macro effects, health and economic macro effects, that therefore reinforces each other. And also, and this of course has been now said over and over and over, we expect these inequalities to be even to be increased or exacerbated by the crisis itself. And so there is kind of a vicious circle at work here, or just a kind of reinforcement inequality. So as one of my co-authors, Laura, has been putting, inequality creates inequality. That's a little bit of how we can interpret this crisis. So I will be focusing, first I'm going to do a few considerations, which I already started on, about inequality and the pandemic. Then I'm going to move on to look into the unequal health impacts, the unequal economic impacts. I'll do a few considerations about the future, which is not really from the papers, but just some discussions and updates about Brazil specifically, because I know that information on Brazil is it's extremely hard to follow, even for me that read Portuguese and I'm in contact with people all the time. It's just so many little details, and it's not like the world actually knows the institutional situation of Brazil. So it's very hard to interpret. So I'm going to try to lay that ground to help you in the future keep reading about what's happening in Brazil and understand it better, hopefully. And then we can, and then already coming into a discussion that I hope we have time for discussion. I'll keep to time. So we have time for discussion. So already bringing up some policy considerations that could motivate a discussion after. So what is it about inequality and the pandemic? How is that inequality affects the pandemic? So as I said, inequality creates challenges to contain the spread of the virus. And that's because there are certain aspects of inequality that makes so that some populations are more vulnerable than others to COVID-19. And therefore, we've been observing that already, but this was an expectation that we had since before the virus hit the US, which is that health and economic impacts would be disproportionately felt by working class, poor populations, and minorities, racial minorities. And also, as also I mentioned before, what we see then, it's because it's already the economically vulnerable population, and already the population that has previous health situations, which I will show, that will be more affected by COVID. We also expect that the inequalities are going to be magnified by the pandemic, as we are seeing. And therefore, this makes that the future is going to be even more challenging. So, and more, I think we have evidence to believe that this is going to become some kind of recurrent virus, something like the flu. I mean, I'm no expert on that part, but there is a chance that this is the case. And then, so we need to consider the fact that if inequalities are becoming higher and people are even more vulnerable in the future, how do we deal with that? And I mean, and one point that we make, I think more directly in the Pandemic of Inequality paper, which is the one focused on the US, is that it is self-defeating not to care for these matters, because this is a public situation, and because we're talking about a virus that when we leave certain parts of the population vulnerable, everyone is vulnerable. So this is an example, which I think really, if I was to give a very short presentation about this and focus on one point, I think this is a snapshot of everything that I'm going to be saying. Of course, as economists, we know that giving you two examples, it's not going to prove a point. So the point is going to be proved with more extensive data later. But the reason why I've been really following closely Brooklyn Heights and Corona Queens, and the reason why is because there was one New York Times piece that came out as soon as New York City released the data on the antibody test for the first time, and they talked about, actually at that point was Cobble Hill, but I looked in the zip code, so it's Brooklyn Heights. But anyways, that's a detail. But they compared those two. On that piece, they compared the positive antibody tests at that point, which was a little below, it was a little different. This is updated data, but very similar to that, where in Brooklyn Heights, you see that 14% of the population had tested positive for antibodies, while 47% of Corona Queens tested positive. And at that moment, there was this questioning, well, so does this mean that Corona Queens is reaching herd immunity? This was a little after, this was in August. So a little after the first wave, before the second wave came. And I was not surprised to see, once the second wave came, that Corona Queens was again one of the worst hit neighborhoods. So about those neighborhoods, so they are about 9 miles apart from each other. And you can see that, I mean, demographically speaking, we're talking about a much more immigrant, non-white, low health insurance, low income neighborhood versus a rich, more white, and not as many people without health insurance, so much less vulnerable neighborhood, although the poverty rate in both is actually rather high. And again, as I just mentioned, the antibody test already tells us a lot of how badly hit these neighborhoods have been. But what is impressive as well for me is that it keeps happening. So when I look into the last week percent of positive tests, it's still Corona Queens being hit harder. And the other problem that we have, of course, they have death rates much higher, case rate is higher, all of those. And the test rate is lower, so they're also observing less of the population. But to the point that we are discussing more now, it's also the case that Brooklyn Heights is vaccinating its population much faster than Corona Queens. So we've been making mistakes during this pandemic, over and over, the same mistakes. So what is it that leads to this unequal health impacts? The first issue about inequality in the health impacts, it has to do with the vulnerability to contamination. The second has to do with previous unequal health situations. So the comorbidities are much more prevalent in poor and minority neighborhoods, as I'm going to show. The third problem has to do with health access, and this is extremely different when we're talking about Brazil and the US. These are completely extreme cases in difference, because Brazil has universal health care, while the US does not, and I'll talk a little bit about that. And then, of course, and this I don't actually talk much about in the paper, or we'll be talking in the presentation, but it's always important to remember, we also observe institutional racism in health treatment. So even if I was able to make all of those equal, you still have the plain fact that when a Black person enters a doctor office versus a white person enters a doctor office, there is difference in the treatment they're given, on how serious their case is taken, and so on. So what about contamination that makes poor and minority populations more vulnerable, and how did I assess this problem? So we constructed, for both papers, the one on the US and the one on Brazil, we constructed indices or measures. In the US one, we actually construct a index using principal component analysis. In Brazil, we really just do a measure where we're adding up binary variables if they are observed to be vulnerable regarding one aspect or not. And the things in general that we took into consideration, and that's by assessing the literature. And of course, there are things that we have data on or not, and that has determined how, what's the unit of analysis that we use for each country and what we added on the measures or not. But thinking about the literature, what is it that could make people more vulnerable to contamination? So the first thing is working conditions. So how far you need to travel, the mode of transportation to work, the type of occupation that you do, and your work environment. Are you working outdoors or not? Are you essential? Are you still working? Are you working from home or not? And so on. Are you in contact with people? The second has to do with living conditions. So a lot has been said in the beginning about, just wash your hands, which now we know that the surface contact is not as much of an issue, but still a lot of people you're telling me to wash my hands, but I don't even have piped water or good water at home. The number of people that are sharing the houses. So when someone gets to the hospital sick and they're sent to quarantine at home, this frequently means spreading COVID to all their family members. Also, number of units in dwellings. So there are some studies that show that during the flu pandemic, people that shared elevators with more people had higher probability of getting contaminated, and so on. And also, who do you live with, and what is your responsibilities at home? Are you the one that is going to be taking care of someone if they get sick? And then, of course, there's also a whole lot to be said about the capacity of avoiding risks, which has to do with, which already has to do with economic security. So, for example, do you have dependents? Can you give up on a risky job? Or you need to, the life of other people depend on you putting yourself at risk during a pandemic. Do you have savings? Can you go to the shop? Can you go to the supermarket and buy already a lot of stuff? Or you're frequently going and exposing yourselves and things like that. So I'm gonna go fast through this one. So this is our measure this is correlating our measure of social risk factors for Brazil, which takes into consideration type of occupation, if you're an informal worker or not. I'm not going to be able to read because there is a bar from Zoom on the bottom here, but you probably do. Access to pipe water and sewage, if you have internet or not, so you can work remotely, and oh my God, if you have a car or not, so how you're traveling to work, and how many people you have in the house. So as you can see, our index correlates. So we don't have micro data good enough to, for example, be able to correlate this at city level. So the most grained we can do here is correlating it by state level, and that's not a lot of observations, but we do see a correlation, a positive correlation between our measure and cases by 100,000 population and between deaths. It is also the case that, of course, this changes over time, the correlation itself. And this has a lot to do with the pandemic. So in the beginning, we actually observed richer people at the very beginning of the pandemic. Was rich people in rich neighborhoods that had, because they had traveled to Europe, come back, and then you have community community spread in richer neighborhoods, and then once it hits the vulnerable neighborhoods, then it explodes. So the correlation itself changes, and it is more, and our index is more correlated to cases than deaths. And that's also expected, because here we're not taking into consideration comorbidities, which we'll talk about a little later, which will tell a lot if you're going to have asymptomatic, non-symptomatic, you're going to end up in the hospital, and so on. So this is our social vulnerability by race in Brazil and by gender. And we do observe that white people, men and women, are below. So our average for Brazil is 1.53. So all white people are below average. Also same with Asian. The indigenous, brown, and black population are all above average in Brazil. So, and we also observe that men are more vulnerable to contamination than women in general, and that has a lot to do with work participation and yeah, I think mostly it has to do with work participation, if I'm not mistaken, the type of occupation specifically. So what we did is to also correlate this, the social vulnerability, to look into the social vulnerability index by income percentile. And what we see is that past the 60th percentile, everyone, all groups, all racial groups are below average of contamination. We also see that white population escape vulnerability at a lower income percentile than Black and brown and indigenous population. So Black, brown, indigenous population up to the fifth, the sixth percentile, sorry, the sixth decile are above average of risk of contamination. And we see the same, well, even a more disturbing thing about when we look into education level. So when we look into Black and brown people, up to people with high school completed, we have social vulnerability above average. And for whites, everyone, even on instruction, are below average. So there's a lot of conversation about, oh, it has to do a lot with the lack of education for brown and Black population. Therefore, they don't have good jobs. They're informal workers and so on. So they live in poverty. That correlation is extremely given by people over and over with regards to this literature. And we show that it's much more about race than about education, and so I think this is very important. This is actually not in the paper, as Yorgos probably knows, because he's commenting it. And so moving into the US, what we did was slightly different, because we have, let's say, well, we have, I don't want to say better data, we have different data. So what we did for the US is that we actually built an index of vulnerability, and also I'm going to have a health risk index. And I do that by what's called census tract, which is like a neighborhood. So it's a geographical unit of analysis. And so I look into the share of individuals living below twice the poverty line. And the reason why it's twice the poverty line is otherwise really there's not that many neighborhoods. Then we don't have as much observation here, which also explains why we don't get such a good explanation for the edge here. It's not that many observations at the end. And the share of minority individuals. And what we observe is that in general, for most of the curve, we see a high correlation and a very strong positive correlation between being vulnerable and being poor, or well, being in a poor neighborhood or being in a minority neighborhood. So for this, I looked into living conditions, the number of units in the building, number of occupants per room, the access and mobility, if they have healthcare or not. And the reason why I actually look into healthcare here already is because of this multiplication issue that we have, and because my unit of analysis is geographical. So I'm saying in a neighborhood where most people do not have health insurance, it's more likely that the virus is going to spread more openly, because people are less likely to go and seek doctor when they're sick and so on. and use of public transportation. And I also look a little into living in group quarters. So this is about elderly population, if they're living in I'm sorry, I'm missing the word here. And if they live with grandchildren or not. So if they are in a vulnerable situation, in a living vulnerable situation, sorry. So the second part of the unequal effects has to do with previous health situation, and has to do with what has been said over and over, the comorbidities. So some socioeconomic conditions are determinant in health outcomes, and this is also something that is widely discussed in the literature. So some of the factors pointed to explain why is it that poor people and minority are more likely to have comorbidities is stress, pollution and cigarette exposure, poor diet, and continued limited health access. And some of the health conditions that have been shown to increase the severity and the likelihood of death by COVID are chronic obstructive pulmonary disease, diabetes, coronary disease, cancer, asthma, kidney disease, obesity, and high blood pressure. So we look into those and create again and look a little bit into how those are unequally distributed according to, in Brazil, we use education, instruction level. And for the US, we have, again, better data to do something more fine-grained. So the reason why we do this by education in Brazil, it's because we only have the information we have on comorbidities comes from the PNES, which is the National Health Survey. And there is not that much data there. There is not good income data. There is not, so it's very hard. The other problem we have, of course, is the questions on the PNES are of the type, have you ever been diagnosed by a doctor with diabetes? So if you're poor, you're less likely to actually have been to a doctor that diagnosed you. Of course, we have universal health access in Brazil. But as I'm going to mention quickly, this is not geographically equally distributed. So there is still, although it is universal, there is still a huge income effect on having actual health access in Brazil. So what we observe is that people that have up to elementary school are much more likely to have the frequency of comorbidities within those that only have up to elementary school is much, much higher. It's 2 times higher than those that have high school and almost 2 times higher than those with a higher degree. And also, as you see, people combine multiple comorbidities much more at the lower level of instruction than the higher level. So in Black here, we have people that have 3 or more comorbidities. And for the US, we did something similar. So we use this very nice database called the 500 Cities Project, which is basically the reason that determined that we're doing everything in census tract is because that data is available by census tract. And that's a CDC simulation and data. They use a model to actually predict prevalence of comorbidities in different census tract. And again, we see a high correlation between poverty in a neighborhood, minority in a neighborhood, and the prevalence of comorbidities. And again, we look into all of those, the percent of population and all of those that have, and we created an index using a principal component analysis. So what about health access? How am I doing with time? Let me look. Okay. So yeah. Health access. So a point here to say in Brazil, as I just mentioned, we have universal health access, but that's not equally distributed among the population. So we actually have a bigger note here on Brazil. We have 2 parallel systems in Brazil. We have a private system and we have a public system. The public system is available for everyone, but because there is always a problem of having enough capacity in the public system. People that are rich or that have the ability to pay, they also have a private health insurance. And those two systems in Brazil, both the private and the public, their infrastructure is concentrated in richer cities, in capitals, in the southeast, which is the richest region in Brazil, and the south. And they have the same. And the other thing is, private and public health systems in Brazil, they have the same number of beds. So, for example, when you look into the intensive unit care number of beds in Brazil, those two systems have the same size, except that the private system serves 30% of the population, and the public system serves 70% of the population, and the public system only 30. So the beds per member, so to say, of the public system is much lower. So we reached the limit right at the beginning of the pandemic, and now came again a discussion on that, which is we ran out of beds in the public system, but we still had beds on the private system. So there were some attempts, and there were some successful attempts of capturing those beds and making it available for public use. The other thing is, and this is what you see in this graph, is that Black and brown people, so almost 70% of Black and brown people count on the public health service, and only about, sorry, no, that's not how you read this graph. I'm so sorry. So 70% of the people that count on the public service are Black and brown, although they're only about half of our population. So they're overrepresented on the public system. They are underrepresented on the private system, and you see the exact opposite with white population. So white population is also about 45% of Brazilian population, but only 30% of those that use private health insurance. And we see something similar as well in the US. So I mean, it was a bit obvious to talk about the fact that minority and poor people do not have health access in the US. That's kind of a tautological statement. But so what we looked into is it true that people that are more at risk that have a higher health risk to COVID are also the ones that are less likely to have health insurance? So this is what we see here. And this, like, just bringing back to the example I gave before, it is the same. It is the neighborhood that has 24% of population without health coverage that is not receiving the vaccine, and that has been the worst hit. So this is what we see. We see that the vulnerable population, not only they are more likely to catch COVID, they have previous health situations that make it more likely for this disease to be severe and lead to death. They are also less likely to have access to health services to treat if they do catch COVID. So I have these three layers of reinforcing problems that affect again and again the same group of the population. And we did a little attempt of trying to see because poverty in the US, poverty and minority population, it's also extremely correlated. So when we look into the ratio of minority and the ratio of poverty by neighborhoods, it's very hard to see what is poverty and what is minority. So we ran a model to try to discuss a little bit of to decouple those two effects, and we find that although poverty always leads to higher vulnerability and higher health risks, the percent of minority have a kind of dependent effect. It changes. It's not linear the same way. We also have some interesting features about, so for example, if you look here, in a neighborhood that is extremely poor, the effect of minority is not going to be as important than the effect of minority on a rich neighborhood. So we see some differences, but I mean, it's extremely hard. This is something I've tried. I've attempted different ways of looking into this. I'm still not completely happy when it comes to intersectionality. It's very hard to be able to make claims about that. But and I mean, this really points to a problem that we have in general. How is it that we can measure poverty effects and race effects and racism when racism is structural? So now moving forward into economic impacts, and again, we're going to observe that, well, first to say that what we've seen happening so far is that we've and this is for the US, there was and the same pattern we observe in Brazil and around the world. The economy has been hit very hard in the beginning of the pandemic. You see a huge increase in unemployment, and then you start observing a recovery after the summer. So around the summer, you start to see recovery. So we see a decrease of in the bottom here, you see a decrease in the number of employed people, the percent of population that is employed, and then we observe an increase again. We've also seen a increase, it's very hard to see with this one graph, but we do observe an increase in the population that is not in the labor force. For one reason or another. So people are also dropping out of the labor force for different reasons. Actually, you do, yeah. So it's all of those three together. That's what we measure here. And again, we have the same problem. It's again the people that are already vulnerable that are the most likely to suffer the impacts, and that's very clear when it comes to the economy, the economic impacts. So it really is people that it really is at the bottom of the income distribution that we've seen the worst impacts. So changes in total employment between February and April, the hardest hit groups are up to, I don't know, let's say about $50,000 per year. And the recovery, also again here, it's hard to see, that's why I have the green bar, but what you see again is that the net effect at the bottom is much worse than at the top, except at the very top there. And same thing when we look into race and gender, and here is where we observe the worst gender effect of the economy. So if women were not the most affected for the health impacts, they definitely have been the most affected by the economic crisis. So again, we observe that for white male and female, although for female the net impact is much higher, it is really the Black female and Latina female that has been hardest hit by the crisis, the economic crisis so far. And we also see an interesting impact by age. And this is something a little different than other crises some people have pointed to. So some people at the New School at SIPA have done some studies on this, talking about why is it that, I think they look more into 60 plus, if I'm not mistaken, but anyways, why is it that this group has been so affected by the crisis? They're supposed to have stable jobs and so on. So there's also a lot to be said about the previous institutional background of the US at that point when we were hit. And in Brazil, unfortunately, we observed something similar, except that Brazil, and now again, a little background here. So Brazil did approve one of the most generous, so to say, or one of the largest relief pacts that has been employed around the world, which was called Auxílio Emergencial. Very important to say, this was approved through a huge organization of civil society and passed by the Congress, albeit all of the efforts of the government, the federal government, to stop. And this is something that sometimes is hard for people to understand, because they see, oh my God, you have this horrible president, and what is happening? How is it that, like, how can you be saying that? But then you got one of the best relief packs that you can see. And so there is something about the way our institutions work and how something can be passed to be said about that. So what we observe is, this is using a data set called PNAD-COVID, which is our household survey. They did a special, they did four special releases during the pandemic. There are, of course, some limitations. It's a phone survey. The sample is smaller than our usual household survey. The data is collected in weird ways, but we have, they are asked a question about what was their usual labor income. We have the observed labor income in May, so we have a pre-crisis May, and then we look into the auxílio emergencial. How much did that cover the loss, or did that more than compensated for the loss? And it actually more than compensated for the loss at the bottom of the distribution, but it didn't get to cover the loss at the top of the distribution. So actually, auxílio emergencial has had two, not to say unexpected impacts, but I don't know, side impact or external positive effects. So to say, the first one is that that poverty levels in Brazil reached the historical lows, and the second one is that it actually decreased inequality. So because of auxílio emergencial up to December, so at December, the auxílio emergencial was dropped, and now they're discussing approving a new round of it, and we can probably talk about that on the Q&A. I'm not gonna enter in that too much now. But what we observed is that if it doesn't get reapproved, it just delayed a certain effect that we've seen in the world, the one of increasing inequalities. And this is the one data from the public note, the policy note that I mentioned from AGE, which is in Portuguese. I did translate the graph for you, but and in this one, what we look into is the effect of the auxílio emergencial by the race and gender of the head of household. The reason why I'm using here head of household has to do with the data. I'm not going to enter in that detail. But what we see is that, and I'm going to focus on this side. So this here is the pre-crisis, the May, the August, and August plus auxílio emergencial income divided by the income of Black and brown women-headed households. So this is the relative income of each of these groups. So what we see is that before the pandemic, white men-headed household had about 2.5 times more income than a per capita income than a Black and brown woman-headed household. That would have increased during the pandemic, both during the first crisis where people lost jobs, but also when they started recovering jobs. Again, we see this problem that Black women not only lost more jobs, but they're recovering it slower than other groups in the population. So even the recovery is increasing inequalities. But the auxílio emergencial has had the impact of making that discrepancy only 2 times, which is already huge. So there's also something to say, it's long due that we have this type of policies in Brazil. So here we are trying to, as soon as we try to relieve some increase in inequality, we are already redistributing to a level that is extremely needed in Brazil. And again, the other thing to be said here, the race factor in Brazil is much stronger than the gender factor in Brazil. Of course, women also suffered more of this with the pandemic and with respect to white men, but Black men are in a more vulnerable economic situation than white women. Sorry, Black men-headed households, white women-headed households, again, unfortunately, I cannot do that unit of analysis. And then with regards to the US, the other data that we looked into is the LIMU, which is the Levy Institute Measure of Economic Well-being. So this is a data set that is produced by the Levy, where we compile data on income, income from wealth. The net government expenses here is not only transfers from the government, but also public expenditure. So for example, we look into each individual, we calculate their income plus income from work, income from wealth, how much public expenses they receive. So it would be, if you go to a public school, we're going to add some to your well-being from that. We're going to give a monetary value to that, and of course net of taxes. So we decrease the amount of taxes, and the value of household production. So we also here look into how much is produced within the household and give a monetary value to that. And the composition of the LIMU, so the composition of well-being is extremely different depending on which decile you are at, or which percentile you're at. So for people at the bottom, of course, income from wealth is not going to matter as much, and government expenses is going to matter a lot, but also household production, it matters a lot. So one of the discussions that we do in the paper is to discuss, so if we're talking about families that are already very stretched in time, not necessarily are able to increase household production that much, and that had their kids going to public school and now don't see that anymore, and that lost their base income, we're likely to see a decrease in almost all of the LIMU components. While for the top, we might be able to observe that these people have more room to increase their hours of household production, and so on. So we also discuss a little bit of this different impacts, and we do a discussion as well, of course, by type of family. So if you're a couple with kids, if you're a single mother, if you're a single father, and so on, and there are many differences for those. And again, the net expenses, so if you see a single mother with kids, 40% of their well-being comes from public expenses, and a lot of that is with public schools. So one of the things that we looked at is the contribution of public education to the LIMU with families by race and family type. And what we observe is that, for example, 26% of the Black single female households well-being comes from just public education. So when a school closes, this affects, that has extremely unequal effects in the well-being of families, depending on their gender and on their race, and if they have kids or not, of course. So this is another aspect of inequality. So finally, heading to the end of this, one thing I want to say is that we're not doing good. Brazil is actually doing worse. Brazil is heading to a second wave that is worse than the first, it looks like. The number of deaths is increasing. The number of cases is still increasing. And so I want to do a little note on Brazil institutions, and maybe we can open more about that. So about the vaccine in Brazil. We have two vaccines being produced in Brazil. One is by Instituto Butantan, which was a coordination between Instituto Butantan in São Paulo and the Sinovac from China, which has been shown to be less effective than others, but 100% effective for example, hospitalization and deaths. So that's already great. And again, this has been done because we have so this is a Gotinha. There was a piece at the New York Times yesterday talking about him. He's our national mascot. And of course, he's wearing the shirt of SUS, which is our universal health system. So he plays for the universal health system team and cheers for it. And he's a anyways, he's a figure that since a kid, when you go get vaccines, he's there cheering for you and helping you go through the vaccine. And so we have this structure built to be able to vaccinate a lot of people, to be able to vaccinate people fast. Before the pandemic hit, we had these two amazing public institutions, Instituto Butantan in São Paulo and Fundação Oswaldo Cruz, Instituto Butantan in companionship with Sinovac and Oswaldo Cruz in Rio de Janeiro, together with AstraZeneca. Although Bolsonaro tried to stop any efforts of getting that, tried to stop the vaccines from being approved. So this is of course, a meme, but it's also a WhatsApp figure that people are sharing in Brazil, and it says, "How may I disturb you?" or "How may I be of disservice to you?" And really, this really is what's happening. We have these institutions that are already established, they exist in Brazil, and Bolsonaro is doing everything he can to make them not work. So finally, this is the very last slide. So a few questions that comes to my mind because of all of this. And here I'm leaving the figure with the vaccine, how it's distributed around the world, because I think everyone needs to look at this and know that this is not okay. And this is stupid, because basically what's happening is that we're getting new strains of the virus in places that are not taking care. This is especially the case with Brazil. Like, everything is open. We have a president that is not even telling people to wear masks. This is discouraging masks and discouraging vaccination. And that really takes a toll on the world and their efforts on getting a vaccine, because if we have new strains and the vaccine cannot be as effective to it, then you're just playing catch with this virus while half of the world is not helping. So one question that I think, and this is more medium term in a way, so how the previous policies brought us here? I think there's a lot to be said when we look into the vulnerabilities about austerity policies, about neoliberal policies in general, workers not being as supported, health insurance, and so on. The second one is, I think the way that we've been framing, well, not we, but that people have been framing as if there is a trade-off between health and the economy is extremely unhelpful, and is part of this discourse as if there is a trade-off, where actually what we need is to solve the health problem so we can have a healthy economy. There is no competition between those two efforts. There is actually a complementarity. So we've been framing this wrongly. People have been framing this wrongly, and this is very unhelpful. The third point is there a willingness to act? So when we look into this and we see that it's poor and Black people dying, what does that do to the willingness of politicians to act? Why is it that they failed so badly to provide, and keeps failing badly to provide support to the vulnerable population? The work that I did for the US, it's all been done with public available data that was available before the pandemic. I doubt they did not know that they didn't. I mean, of course, it was a government that was not putting too much effort, but that no one warned them that it would be Black and poor people dying from this. It's very hard to imagine. And then finally, one thing that I think comes for me as well is this difficulty of making universal policy. So for example, when we make a universal lockdown, that doesn't solve the problem, because we have structural racism, we have poverty that is reflected in multiple dimensions. So we really need a coupling here where we are providing more for those that are vulnerable, lifting them up, and also adding universal policies, which themselves are redistributive. But we need really the inequality that has gotten to a level that just counting on the distributive impact of universal policies is not going to do. Okay, thank you.
Thank you very much, Luiza, for the presentation, and right on time, actually. So I'm just gonna let Yorgos make his couple of comments, and then we can open the floor for questions from the audience.
Great, thank you, Jose. Luiza, thank you very much for this very, very interesting presentation. I really enjoyed reading both the paper and report, and listening to your presentation. These are some fascinating findings about the ratios and gender structures of inequality in COVID contamination, as well as economic inequalities related to COVID. So my understanding is that there are two key contributions in this work. On the one hand, you contribute empirically to a literature on social and economic epidemiology. It's about the social conditions and economic conditions that create the necessary conditions for a virus to spread more quickly, and then how COVID itself will affect economic institutions in the future. I think that you might have more than one papers there, to be honest. I think one of the weak parts of the paper was the transition between the two. It might be worth focusing separately on those matters, would make it more focused, I think. But based on that, I would say that the results are very, very interesting. And if you do that, you might be able to theorize a bit more how exactly, what are the mechanisms behind the social and economic conditions that affect contamination and the dynamics of COVID. You showed us really the correlations between different social and economic conditions and the waves of COVID. But I think it's not a problem in your paper alone, it's a broader problem that this is a very under-theorized area. And I think with these interesting findings, you do have the chance to also theorize how exactly these social economic conditions create these longer or more or deadlier COVID waves. For example, are the causes behind, say, the housing crisis in Brazil, in big cities in Brazil, and big cities in the US the same? In the US, one could say that it's financialization and whatever decline of social housing might be key behind that. Is the same story true for Brazil, or something different? So you might need a more historical institutional narrative to explain these findings, I guess. Also, what might further strengthen the paper, and what would be interesting in terms of substance, is if you could split this risk index, this index of social and economic conditions, into its components. So say the correlation between, say, living conditions alone and COVID infections, workplace conditions alone and COVID infections. So you can compare in different states, different neighbors, which was the most important factor behind the infection waves. Yeah, and overall, I would like to hear a bit more, if you have, based on what I said before, what would you say are the key similarities, humanities between the US and Brazil in the context of social and economic institutions and their impact on COVID? What are the key differences? So to speak, I would like to hear a bit more about what might be some universal mechanism that is a link. There's a solid link between economic conditions and infections, which might hold across countries, and what is special about those two case studies. Again, thank you.
Thank you.
Thank you, Yorgos. Luiza, maybe you want to take those comments and reply to them quickly, and then we can open the floor.
Yes, of course. Thank you. Okay. Well, let me point to a general difficulty with this line of research, which is we started this, we were playing catch with it all the time, right? So I started working on the US paper in February, when no one was talking yet about inequality. And then I released the blog post very quickly when the very first thing came on New York Times. It's like, oh my God, they're saying what I'm saying. I need to say something. And then we got the policy note, which of course, again, was it is focused. And I think there is something to be said about contributing on this general discourse and correlation and macro and micro, which is why we've put together a team to discuss this. So the paper is co-authored between me, a friend who is a doctor, and did more of the part of discussing the epidemiological literature. Then we have a microeconometrist, which is Fernando. We have Tom, which is discussing more the micro economic effects, and we have Mihalis, who is discussing more of the macro effect. So we really wanted to do a general discussion that could help us explain, one, why is it that it's self-defeating not to care of this in a macro level, and kind of really talk about this long arc of it. I think there is so much to be contributed when we go into the details here that I even get lost. So for example, talking about looking to the components, I've done that. Like I have the data in front of me and then I start going crazy and then I start opening up. And I did give a presentation of this for the Boston Development Group, which is people related to the mayor. And for that, I did that. I started looking especially at Boston. What can I see here? And I think one of the contributions that this could have given, but of course no one cares, it does allow us to think a little bit better on how to distribute these vaccines. So if you are really, what we're saying is this matters more than just saying, I don't know, you can do a better job than just saying people 65 plus. You can do better than that. So it could be used, easily used, to try to distribute vaccines more carefully. So I think also one of the contributions is exactly to point how there is not willingness to act politically. So I think this is kind of, which is of course not discussed there, is more of a meta point, but to say that, yeah, I mean, if we can do better with public data there, of course, the government could be doing much, much better. The other thing, the key similarities. If I need to point to one similarity between the US and Brazil, I am going to point to the history of slavery. I think for me, this is the most distinct fact, because really, no matter how I cut this data, no matter how much fine grain I go into it, race seems to be the most important factor here. And it's not race just because it is, as I showed before, it's not just because race is correlated to poverty. It's not just because race is correlated to education and so on. It is race. And I mean, and this is why once I got the results for the US, phrasing in a more general is the fact that both of these countries are very unequal. And this is why I thought, so I started doing the work on the US, and then I started talking with Laura Carvalho, and we were like, okay, let's replicate this to Brazil and see what we get, because of course, structurally speaking, inequality is very similar in those countries. And the key distinction for me between those two countries has to do with the fact that one country has no universal healthcare and the other does. So this has to do with how easy it would be for one country to respond and how hard it is for the other country to respond. And bringing here another similarity that now is not as similar anymore, the governments, the federal governments that were in place at that point. So Trump and Bolsonaro have been pointed by many people as being similar. And I think this explains, so really, inequality, slavery, Trump and Bolsonaro, for me, these are the three main factors that explain why is it that Brazil and the US are the two most worst hit countries in the world by the pandemic.
Thank you, Luiza. Thank you for the reply. I don't know if anybody from the audience is keen to ask a question, and maybe I can promote them to join the panel. I see Oriol has a point saying, in fact, slavery in the Americas was predated by a massive pandemic brought by rich white Europeans. Which is actually true.
Yeah, and it's similar. So as I was saying, sorry, I'm going to have to point on that, which is exactly what we saw. It was the rich white people traveling to Europe that brought the virus. That definitely was the case in Brazil.
So in the meantime, I can also probably point out a very similar. So, Luiza, you've referenced this New York Times article that was published, and I had the chance to take a look at it also myself. One of the things that they point out is that apparently Brazil has a very good sort of like history in terms of vaccination, because you have some sort of institutional framework, very good institutional arrangement for that. I would like to hear your thoughts about, vaccination efforts going further on that sense, but at the same time, I mean, relative to other countries in Latin America, I know also that Brazil has a very also comprehensive structural welfare system, right? So I would like also to hear your thoughts on that, on how you think things are going to move forward, and in terms of both vaccination and more welfare packages in Brazil.
Okay, so just a note here to Unegual. Thank you. And let's talk more. You have my contact. It would be great to talk more. I'm very interested in what you're working on as well, of course. And with the vaccination, I think, I mean, we're going very slow. Part of the problem is we have so many, how do you say, gargalos, bottlenecks in the production of the vaccine. Some of them haven't even really, we don't have enough syringes. How do you say that in English, the thing that you use? Yeah, we don't have enough of that, but that hasn't become a problem because we don't have enough of vaccines. And we don't have enough of vaccines because the government is not able to guarantee the importation of certain things. So we have a huge diplomatic difficulty. There are so many problems. There was this heartbreaking video that came out at some point of as soon after the vaccines were approved in Brazil, and it was very interesting to so when the vaccine was approved in Brazil through this publicly held meeting of, I don't know what would be the CDC of the US, but of Brazil, and was live on YouTube. And really what you saw was people watching it and cheering as if it was a football game, and discussing it as if it was a football game. And really we made a goal when they approved the first vaccine, and then another one when they approved the second vaccine. And really it was very moving to see that. Soon after those two vaccines were approved, and already that had been an effort both by Fiocruz and by Butantan of producing a huge amount of that, there was this heartbreaking video of this person that works at Fiocruz coming out and saying, we did all that and it was useless because now I just heard we do not have the inputs to continue production. So as I said, really, there is a lot of effort from civil society, from people that are from the public structure, and Bolsonaro is there disturbing all the way, to the point that, yeah, the latest one on him is he came out and said that masks should not be worn because, citing whatever, I don't know, studies saying that it gives headaches and creates foggy mind or something like that, whatever. Anyway, so he's not even telling people to wear a mask, which has no cost, really. So that's a little bit on the vaccine side, where we're at. Regarding the oh my god, regarding the package, the package. So what's happening on that now is we haven't been able to approve the budget for 2021 yet. We do have a very strict fiscal rule in Brazil, which is called Teto dos Gastos, which is the expenditure ceiling, which has established as a it is an addendum to the Constitution. So this is established by the Constitution now and cannot be changed that easily. That for the next 20 years, this was established in 2015 or 16. I think it's 16. Sorry. That for the next 20 years, percent public expenditure as measured by percent of GDP could not increase. So, sorry, was not as percent of GDP, that not even as percent of GDP, that the level of expenditure at that year would not be increased for 20 years. So it actually would be decreasing as a percentage of GDP assuming GDP grows, of course. So they are tied by that. There is difficulty getting a budget approved. And right now they are trying to approve this as an extraordinary expense. So they're trying to approve a new auxílio emergencial as an extraordinary expense, but it is extraordinary to a budget that has not been approved. So there is it's very hard to follow because there's so many constitutional problems on the way they're trying to do that. And of course, the Minister of Finance, who is a Chicago boy, Paulo Guedes, doesn't really want to get this. There is a lot of, it's not only the fact that there is a ceiling that institutionally ties their hands on how much they can expand. There is also a true belief on society that austerity is a thing, that the public debt is a problem, and people are like, but where are you going to get the money from? So it's not only about getting the money approved in the budget, but also about people, so then they tie this, this attempt to make it an extraordinary expense to decreasing expenses in public education, which they wouldn't need because it's extraordinary. But anyway, so there is a lot of discussion on that, and basically what we have is both institutional austerity, like already established in our constitution, and a belief, an ideological belief in austerity really is making it extremely hard to get this approved.
I'm actually very glad that you touched upon that particular subject, particularly because we have a question here by Diogo. I hope I'm saying your name correctly. He's saying if he wonders if there is a correlation between the pandemic crisis, so I assume he means the negative effects of the crisis, and what he calls the financialization of the health system in Brazil, particularly because of the budget constraint that you very well expose right now, but also because that, he points out, implies a growth on the private health system that could lead to potential more inequalities.
I mean, before the pandemic hit, there were some discussions, and this goes both for public health and public education, which we also have in Brazil. But before the pandemic hit, there has been a lot of discussion on kind of adopting a system closer to the one in the US. So I mean, you take the most inefficient system in the world and you mirror yourself on it. But so of course, with the pandemic, this changed a little bit. The pandemic has, if there is any silver lining here, has brought attention to how important it is to have public health. So the SUS has been, SUS is our system, Sistema Único de Saúde, Unified System of Health, has been a lifesaver here, really, and population in general is able to see some of that, except we have 30% of Brazil that is with Bolsonaro. No matter what happens, they are with him, no matter how absurd something is. So they are going to be against anything. They're going to be against masks no matter what. So I'm talking here about the known, what we call Bolsominions, the really like strong Bolsonaro cheerers people. But so there is both a move forward with the discussion of the importance of having a public health system, but also in general the role of government. And I think this is something about the world, right? We've been seeing the role of government, that the government should intervene, and the government needs to release these packages and need to promote the stimulus and so on. And of course, this has created some revival in heterodox economics and Keynesian economics and so on. So this discussion changed a lot since the pandemic, but we are slowly moving back into whatever was before. I think the correlation I would say to answer that is that the worst is our health system, and of course this has a lot to do with the budget constraint, the teto dos gastos. The worst is the pandemic, of course. So if you come already if we started the pandemic already with a underfunded health system, this has had the impact of having things go really wrong. And I want to point here to what happened in Manaus not even a month ago, which was that they had a problem with running out of oxygen in the hospitals, and people were suffocating to death because of lack of oxygen, which was not even again, the problem here, the bottlenecks are regional. It was not even a national problem. It's not that it lacked. What they lacked was so for example, the situation got to a point where the problem was that the only airplane that Brazil had that could carry the oxygen was broken. So this is kind of the situation that could take the oxygen from different states and bring over. And then we had this huge mobilization of artists buying oxygen from the Southeast and sending it to Manaus. And it's like, really, it's a huge effort to bring a ridiculous amount of oxygen, as you can imagine, because we had no way of bringing it properly. So this is the type, this I think is where we see the worst part of the underfunding of the health. It's really regional. You need to go into certain cities, certain center counties to see how this has affected. It doesn't really, it's not something you'd see on the Southeast where you have so much private health and so much, although we are reaching a limit there too.
I have someone from the audience that wants to make a comment, so I'm going to promote them to the panel.
Mm-hmm.
Yorgos, you can hear
Yes.
us. I think you can speak if you unmute yourself.
Yes. Can you hear me? Okay.
Yes.
Hi, Luiza.
Hi, nice to see you.
Nice to see you as well. So let me, because the connection is not good, let me do this. So yes, I mean, I have a comment. I don't really have a question because I've been thinking and working on similar things for the last 6 months or so, probably a year actually by now almost, since the beginning of the pandemic. And there are two things that I have in mind. So I have one paper which is forthcoming now in Social Science and Medicine, where we have an epidemiological model where the probability of transition becoming from susceptible to becoming infected is socially defined, is defined by socioeconomic conditions, which in a way is very close to what you're saying, because I mean, we have about global inequalities, but if you think about it, so the more poor someone is, or the more vulnerable someone is, the higher would be the probability of going to work,
Mm-hmm.
or then having a specific type of work where they cannot work from home, right?
Mm-hmm.
So they would meet more people on average,
Mm-hmm.
which means that on average they would it would be easier to get infected. At the same time,
Mm-hmm.
more vulnerable people live in the same house
Mm-hmm.
and in the same block of flats and the same neighborhoods and everything with other people. So there is like a feedback effect. So I think this is something that, and in a way your findings are an empirical example which show this kind of theoretical issue.
Mm-hmm.
And then something else which is related to a comment by, I don't remember their name, on financialization.
Mm-hmm.
So we have a, sorry?
Diogo was
Yes.
the person that asked the question, sorry, yes.
Yes, thanks. So we have a paper, hopefully will come out soon with the other Yorgos sitting next to you on financialization and health. And the idea is actually the fact, so this will be hopefully in sociology of health and illness. And the idea is that, you know, on one hand, financialization has been a big thing in political economy and heterodox economics and other disciplines relevant or closely related to political economy, like sociology and politics, etc. However, it's almost absent, and this is a very good comment, I think, that the other person made. It's almost absent in social epidemiology, social health, sociology of health, etc. So social medicine, all these type of things. So and this is interesting. I make one more point. I mean, this is a bit of a detour, but the fact that diseases are socially defined comes from, in a way, Marx's book on the conditions of the working class in England, which for some it's the first text in social medicine, actually, which is interesting, right? So Marx has said everything, and okay, I'm exaggerating here, but the idea that it is socially defined, and we know from the financialization literature in political economy that financialization has defined a number of social conditions, right? So financialization has defined, I mean, it takes bargaining power of workers, so it makes them more vulnerable. At the same time, if you think about it, because you mentioned about debt, this has it puts barriers even to governments who would like to do something, especially in developing countries. So I think that's another kind of interesting point of view. And one last comment has to do, I think it would be interesting for someone to check some, so US and Brazil are very unequal in terms of development, right? So US is much higher, although Brazil is relatively, not relatively, it's a poorer country, right? However, we see, as you mentioned, these similarities due to politics. And this is, I think, a very important issue. And I don't know what, I think that would be interesting to check what happens in different countries. Because, for instance, in Greece, initially it wasn't as bad, even though the government is from right to far right, I would say now, given a number of things that they're doing. But this is, I mean, it would be interesting to see how this political type of influence could be generalized. Yes, sorry for speaking too much. Thanks.
No, of course not. Thank you, Yorgos, for your comments. Actually, that last one very nicely ties up with one extra question that we have here by Matthias. He is asking Luiza whether she thinks, how do you see the ideological momentum on the role of government in the economics debate, both in Brazil and the US? And do you believe that we're going to witness a reversal or some small reversal on how the government acts to guarantee social rights between these two countries?
You mean a reversal going forward, like past this?
Like in
general,
like, well, I can only interpret what Matthias means, but I assume that he means that a change of perspective, like whether
I
we're going to
don't think
see.
so. We are already seeing that we haven't even solved the crisis, and we are already going back to a very strong austerity discourse. This is extremely distressing for me. We thought so at the beginning, like when we started moving forward with this type of conversations and this, I don't know, I thought that, we're suddenly, the world is going to see that where all this money come from. We've been talking like that people would suddenly realize, oh, the money's there. That's not, the problem is not the money, the physical money. It is productive capacity. Anyways, I thought there would be a move towards a less I don't know what Kelton calls deficit hysteria, and I have a friend that calls deficit public fiscal terrorism that we have. And I don't think so. I think it's still there. The fiscal terrorism is still there. And to cite a very recent headline in Folha de São Paulo, which is one of the biggest newspaper in Brazil, which was saying that approving the auxílio emergencial, the new auxílio emergencial package was a hyperinflationary suicide. So no, the discourse has not changed. And tying, I don't know, it's so many questions. So because Yorgos came up with so many interesting points, and let me say a few things, a few comments, really sparse on things that I put notes here, but we should talk again. We have a chat contact, it would be great. And with the other Yorgos as well, we can meet at some point and discuss these things. I think there are a lot of things to be discussed. And one thing, I do not know, we're seeing the rise of there are two things now. The pandemic is going to be very different going forward. One, because we have, of course, this discrepancy on the populations that are being vaccinated and the population that is not being vaccinated. That's one thing. The other, we have these new strains that are rising, which seem to be more spreadable. It spread more easily. So in the beginning, there was a lot of people saying, "Oh, the virus does not discriminate." That's wrong. The virus does discriminate. The virus itself discriminates. There is an epidemiological matter here that is at the heart of this discussion. That is at the heart of why is it, and this is where I started from, which is the part of the comorbidities. And then, of course, moving towards the socioeconomic, which are already transparent and correlated with the comorbidities itself. Diabetes is a poor person disease, and so on. The other thing I want to say to Jorgos about Marx, the working class, and this is a general comment that I mean that's where my work in general, more going out of even COVID research here goes, is when we move, and this is a move that is necessary in contemporary times, and feminists have been talking about that for a while, but also Black scholars. When we move from thinking of working class as the unit of analysis here, and we start thinking in intersectional matters here, and start thinking of other vulnerability groups, what does it mean? And one thing that for me is very interesting when we think of what is it that makes Black people in Brazil and the West so vulnerable? If it's not only about the poverty, it's not only structurally and systemic in that sense. There is something to be discussed more carefully there, I think, and looked more closely to understand the discrimination and the working conditions and the segregation in segregation in the labor market for women and minority populations. It's not a proxy of education. It's something else, right? So it's not only a class matter, so to say. And regarding that, one more thing, because the other Jorgos earlier asked about what is it that the similarities of Brazil and the US, and I want to talk about sovereignty here. So both of these countries have a huge fiscal space when it comes to being able to emit that, except in Brazil because of course, the taxa dos gastos again. But Brazil does not have international debt. Brazil has this fiscal space, and the US, of course, has a lot of fiscal space for so many reasons. So this was not a constraint for Brazil. Again, the US, yes, it is richer than Brazil, but Brazil does have that advantage regarding having universal health care. So what is interesting for me is, although those places had many advantages with regards to the rest of the world, they are the ones really messing this up the most. They are the worst too, and they had so many advantages on tackling this. And really one thing that comes to me, and this is, I can only say that to the US as someone that is mad and that is oppressed, of course. You have a responsibility towards the world. If you're an imperialist hegemony power and you have this ability, you have a responsibility of really keeping it in check. The US had a responsibility of dealing seriously with that. China dealt seriously with that. There's a lot to be said and criticized about China, but they took it seriously. The US did not take it seriously. And it's the exact same thing that I say to people that are out in the streets in Brazil right now and pouting, and they really are. The videos of Brazil is ridiculous, It's not about your health. It's not about your country's public situation. It's about the world. It's about other people's situation. When you go out and you expose yourself, someone that you don't even know is going to die somewhere. Some country is going to get messed up. So, and the same goes to Brazil. Sometimes I talk with Jose and I say, I'm sorry about what my country is doing to our region. This is absurd. And you see that spills over borders. Anyways, regarding that, I just want to point to with privileges comes a lot of responsibilities, and Brazil and US does not understand those.
Okay, thank you, Luiza, for that great intervention at the end. I think
I am mad, as you can see. As I
think
said in the beginning, I'm coming from like really
with anger and frustration,
yes,
I can see that.
yes.
But I want to thank you regardless for coming here and sharing your anger and your frustration with us, because it also produced very good research. It was quite illustrative of a presentation, and I'm very, very happy to have you here. I also want to thank both Yorgoses for their comments and other audience members for their questions and so on and so forth. So thank you very much, and we'll catch up in the next seminar series. Bye-bye, everyone.